Had a guy send me his labs. 3 weeks ago. We went over them November 29th on Zoom. I've been working with him for about 6 months. And so I thought I'd show you these labs and show you what you can get on your own. He ordered these on his own. He wanted to know how his body was doing. He is on testosterone replacement therapy with Bitest. He takes 200 milligrams of a 90% mixture of testosterone enanthate and testosterone cypionate once a week. He's on sermorelin, which is a human growth hormone release hormone, which we can do a whole video on human growth hormone releasing hormone. He really has a couple of medical conditions that I won't go into, so he can't be identified at all. He takes 2 prescription medicines and he takes some supplements. So let's look at his labs that he ordered from Life Extension. So this is the result that you get. I've blocked out all the identifying information on him. Drawn November 16th. That was done 7 days after a testosterone injection. And these are the labs you get for what's called a male panel at Life Extension. The lab that's doing the tests are LabCorp. So you get a comprehensive metabolic panel of free and total testosterone, pregnenolone, dihydrotestosterone, thyroxine, free, direct, TSH, DHEAS, which is dehydroepiandrosterone sulfate, and a cortisol. And notice it ends. So it is supposed to have a high sensitivity C-reactive protein, a homocysteine level, an apolipoprotein B level, a fasting insulin level. So I need to call Life Extension and ask them why wasn't that part of his panel. So he ordered this direct on Life Extension. He got the results and forwarded them to me, and we went over them together. So here's his comprehensive metabolic panel. So a kidney screen, these are electrolytes, his liver function tests, and notice he has one liver enzyme, ALT, SGPT, that is elevated at 70. He had to take one of his prescription medicines that can be hard on the liver for an outbreak of a medical inflammatory condition the week before these labs were drawn. So I chalked that up to that medication. He is not an alcohol drinker. He doesn't drink at all. And then his lipid panel, and this is the one that everybody's going to focus on. And I will preface this by saying he is completely adamantly opposed to taking a statin. He's done a lot of reading. He is well educated. He reads. He has looked into a lot of different options as he ages. He's 53 years old, on how to age gracefully. And his big issue is his weight. So when I started working with him, he weighed 470 pounds at 6'1". So his body mass index, if you buy into BMIs, was way up there. So obesity is considered 30. He was in the 50s. So let's hone in on this a little bit. So his cholesterol total, 317, triglycerides 232, HDL is 22. That's one of the lower ones I've seen maybe ever. And his LDL, 247. So everybody focuses on this one, total cholesterol, and LDL. And so every doctor he's seen in the past several years has tried to put him on a statin, and he won't do it. So the question is, me as his health coach and working with a collaborative physician, what do we tell him he should do? So he has used testosterone replacement for several years. The doctor that he felt the most comfortable with and felt the best on his regimen retired. He went to an endocrinologist who was not treating him effectively, he didn't think. He presented to my collaborative doctor and me. We have him on this regimen. He feels fantastic. And the important thing for him is that he's lost 77 pounds. And so that is more important to him, and he feels that's more important to his health than his cholesterol level. So he has dropped from 470 to 300, so 77 pounds, so 393 pounds. His BMI is still around 50. And he does not look, when you see him, he does not look obese. So he's a fairly big, muscular guy, works out a lot, and he's changed his diet. And we'll get into that in a little bit. So let's look at the absolute numbers. Every doctor is going to tell him you need a statin. So let's look at the ratios. I've told you before, ratios, I think, are more important than numbers, absolute numbers. So his total cholesterol by HDL divided by HDL is 14.4. That should be under 5. So if you look at the risk ratios here, an average risk for a man is a ratio of 5. So 0 to 5 is normal. Half the average risk, 3.4. He's at 14.4. So they're calling his estimated cardiovascular disease risk 2.4. So that's a calculation based on 1 being no higher than the general population. So they're saying he's 2.4 times more likely to get heart disease, heart attack, or a cardiovascular event, stroke. He does have high blood pressure, and he takes 2 medications for that. So let's look at the other ratios. So life extension, or at least LabCorp, looks at total cholesterol divided by HDL. The other ratio you can look at is total cholesterol divided by LDL. So 317 divided by 247. And I could do the absolute number, but it's less than 2. So if you look at this risk ratio at 2, he would be a little bit less than half the average risk ratio. So if you divide total cholesterol by LDL, which is what a lot of people do, he's just, not even 2. And then to me, the more important, and for other doctors, the most important, is triglycerides divided by HDL. So 232 divided by 22, he's over 10. So that should be less than 3. And so he's way over that. So he's 3.4 times higher than the ratio that's recommended. So what we don't know is his standard inflammatory marker of high sensitivity C-reactive protein. We don't know his homocysteine. We don't know his ferritin level. So that's next. He ordered this. We're going to take this information and go further into his cardiovascular risk factor, since he will not take a statin. And I agree with him. You can't force people to take medications they don't want to take. So if we approach cardiovascular disease as an inflammatory condition, which is, even in my physiology textbook, is now the prevailing thought, that high sensitivity C-reactive protein is more predictive than LDL absolute level. That's a statement in a copyrighted textbook from which I teach that was copyrighted 2022. So that's what everybody's going to focus on, is his cardiovascular risk, and maybe sort of ignore the fact that he's lost 77 pounds. And I'll tell you how he did it working with me. His white blood cell count, 11, just a tick over high. So let me move this so you can see a little better. So 10.8 is upper limits of normal, but he had an inflammatory outbreak of a chronic disease the week before. His red blood cell count is high. He's 5.91, and you a little bit high, and you see that in some men with testosterone. So it generates production of red blood cells from the bone marrow when you're on testosterone. Not everybody. And notice his hematocrit is 49.8, so he's ticking up close. We kind of pay attention to hematocrit when it gets 52, 53. I worked with a internal medicine collaborative physician in St. Louis a few years ago. He was an internal medicine doctor and recommended all men donate blood as often as they could to get their iron stores down and keep their hematocrit in a reasonable mid-40s range. So he does that. He has made an appointment for his next blood donation. He's not so high that I'm not going to say anybody has to donate blood, but a lot of men on testosterone that produce a lot of red blood cells do a Power Red donation every 105 days, I think is what the Red Cross recommends. So his neutrophil count, the most common white blood cell count, is just a little bit high from that inflammatory condition. Now, on testosterone. So by test, testosterone enanthate, 90% testosterone cypionate, 10% mix, compounded at 200 milligrams as an injection once a week. His testosterone total is 893. So those of you that follow total testosterone would think that's a pretty good level. The idea is to get him over 600. Cenogenics in Las Vegas recommends men get up to about 1200. My doctor and I look at free testosterone and bioavailable testosterone. 24.4, the goal is 18 to 22 and a half, 23. He's a little high. But then if you look at the breakdown product of testosterone to dihydrotestosterone, which is a 5-alpha reductase enzyme conversion to the active hormone at 41, he's right there in a good range, 30 to 85. So he's converting to 41. Some testosterone can convert to estrogen, estradiol, and he does that. So I'm going to bounce back and forth. So he was at about 768, I believe, in August. He is on dimclomifene every 4 days, and now his estradiol is 30.2. So that took care of some of that conversion. Pregnenolone is one step away from cholesterol. It's made directly from cholesterol. It's less than 10. My guess is he has a little bit of anxiety and adrenal hyperfunction, although his cortisol is normal. He did it at noon, 7.1. And so now I want to see what his cortisol metabolomics looks like and his hormone metabolites by urinary testing. So that's part of the next investigation as to what his body is doing in total. His dehydroepiandrosterone sulfate at 108 in this range is normal, and that goes down starting at age 40. So it's based on age, and this is a reference interval across the spectrum from like 20 to 65, 70 years old. Men do really well about 350 to 400. So to me, that's low. I'll probably get a little flack for that, but to me, DHEAS men do better at about 350. They feel better. If DHEAS gets too low, you get fatigued and lethargic. There's a term, it's not a medically coded term, called adrenal fatigue based on DHEAS levels and symptoms. Cortisol 7.1, excuse me. TSH under 2, normal. Estradiol 30.2. His other thyroid free direct T4 is 1.19. So we like to see, this does not give you the full thyroid panel, which is what I like to see, but this is what's on the Life Extension Male panel. So on this one, you want a TSH less than 2, you want a free T4 over 1. So he fits that criteria. His PSA, prostate specific antigen, is coming in at 0.5, and that's actually gone down since he has been on testosterone replacement. And we see that fairly often where men, everybody worries about prostate cancer. Testosterone does not cause prostate cancer, but it will grow one that is clinically or subclinical, like you don't know it. So we watch PSA levels fairly close. His went down, which is 90% of the time is what I see, is a man has a very low testosterone level. You get it in a good range and their PSA goes down. Sometimes it'll go up. So PSA can go up with testosterone replacement, but testosterone replacement is not the cause of prostate cancer. That's from Abraham Morgentaler at Harvard. The men that get the aggressive prostate cancers are under 60 years of age with a total testosterone level less than 350. He did that study quite a few years ago, actually. So that is what he looks like. He's 53. He feels great. He will not take a statin. So the advice from the collaborative physician in me is to do a deeper dive into particles, lipoprotein particle size and number, the type of LDL particles, looking at myeloperoxidase, LPA-PL2 levels, homocysteine, ferritin. And so we will have to put together a package for him to order that direct. He has catastrophic insurance, so he pays for everything. And I don't know what his deductible is, but it's way up there. So he pays for everything direct, and gets, a panel like that would be, a retail price at Quest would be up in the $3,000, $4,000 range. I looked at Quest to see if you just went in and said, okay, I want to have these tests, the ones that he had done, and just pay for it direct. And it was right around $1,000. If you have insurance, you can get a test like that, depending on your insurance contract, fairly reasonably priced, if not no copay. Depends on, everybody's insurance contracts are different. So you just can't make a blanket statement, oh, go get this, it'll cost you $25. That's not true. But for him, this was $299. He, for supplementation, is now taking pregnenolone and DHEA. He is also taking sermorelin, which is a human growth hormone releasing hormone, which he started in September. So he's in, October. So he's in his second month of sermorelin. And what he's getting from sermorelin is he sleeps like a baby. His mental clarity is very, very focused. He's able to think very well. His muscular development, his workouts are better, he thinks. Of course, testosterone plays a role in that as well. So sermorelin is the newest for him. He's on coenzyme Q10. He is on no medications for insulin resistance. And unfortunately, that test, which is supposed to have a hemoglobin A1C and a fasting insulin, didn't run it. So I've either got to get them to send him another kit and have them run the rest of the kit, or maybe they'll send, I think probably they'll send him a kit and just not charge him for it. Because he was missing the tests that I told you come with that kit. He is also, and I know I'm all over the place, but ADD doctor, what do you want? So he's on CoQ10, pregnenolone, DHEA. He takes niacin. He takes omega-3s. And he is starting on chondroitin sulfate. So if you go back, I did a video wrap up after a guy at Loma Linda did 50 years of research and found that chondroitin sulfate specifically, not glucosamine, chondroitin sulfate could reverse cardiovascular atherosclerotic plaque and prevent it by improving the glycocalyx lining of the endothelial cells of arteries. So he's taking that as well. He takes a complex B vitamin injection about once a week as well. So he's getting after it. He is now keto carnivore in his way of eating, and he does intermittent fasting. So he eats once a day. So he's on a 23-1 intermittent fasting regimen, or timed restricted eating, I think is probably a better way of saying it. So he has significantly reduced his carbohydrates, and since June 1st, he's lost 77 pounds. So he is ecstatic about that, and really kind of completely blows off the cholesterol thing. He doesn't think that's of interest at all at 53. So what say you? What do you think? What would you tell this guy based on what you learned and what you've read about, those of you that have not bought into the cholesterol hypothesis and have looked into the fact that cardiovascular disease is really a disease of chronic inflammation, insulin resistance, if not type 2 diabetes, and continuously elevated insulin levels from eating all the time. And if you keep eating, your insulin level is high, and eventually your cells just ignore insulin. That's insulin resistance. And if you do that long enough, you get to be a type 2 diabetic. And the leading complication of type 2 diabetes is heart disease. So that's class for today. So Life Extension Male Panel. If you want to get one, get in touch with me. I'll lead you to the right place. This guy is going to do a 24-hour urinary metabolomics test through Physicians Lab, and he's also going to do a 24-hour hormone panel by urinalysis by urinary metabolites, also through Physicians Lab, coming up. So we will look at him much more in depth from an inflammatory angle for his cardiovascular risk disease or cardiovascular risk. So have a great day. I'll be back soon and talk to you later. Bye.